All right, this is going to be a lecture on financing and reimbursement methods. So the learning outcomes is that I would like you to know the overall purpose of insurance, that there are different types of health insurance and plans. I want you to understand the basic insurance financing terms so that if you see the terms, you understand how they work, how we have a third payment system model where we reimburse the provider using health insurance, and I'll talk a little bit more about that. Know the ACA impact on private insurance, and I have an interview that I definitely want you to watch so you can understand what the Affordable Care Act did and when it came to Medicaid expansion, but also how it impacted private insurance too. And then I will not take a deep dive into the sheer complexity of the reimbursement system, but please know that there's a whole field called health information technology that does a deep dive on the technology and the billing system and how they use technology and all the insurance codes called ICD-10 codes. I just want you to be familiar that there is a reimbursement system that lives out there. So these are the basic themes, and in your discussion post this week, I'm going to put you in groups, and then I'm going to ask you to do a deeper dive into these themes. And in this lecture, I'm hitting on some of these themes, and your book each has a different area. So this lecture coincides with the book. We're going to cover basic insurance concepts. There are different private insurance types. So if you have an employer and you get insurance from your employer, your insurance can vary by different types. And the Affordable Care Act and private insurance, and that's key. It definitely made an impact on private insurance, on what it needed and what was required to cover. I want to make sure that you understand what Medicare is and what Medicaid is. And then I'm going to ask you to select a reimbursement model, and you have to at least pick one. And I think in the discussion post, I actually ask you to do two. And that they're payment reform initiatives, because how people get paid is how it really influences what services are provided. Think about that, and we'll talk about that. So beginning, health insurance. Insurance is basically any mechanism that gives the people to pay for healthcare expenses that might be above and beyond what they expected. It's the idea that health insurance is for large and unexpected medical bills. Now, in most cases, if you did not have health insurance and you have some catastrophic event happen to you, you probably couldn't go into a financial reserve and pull out $300,000 for a few days in the hospital. So think about this. Health insurance is key for really those unexpected and large medical bills. There are four big principles of insurance. One, that we know that risk can be unpredictable for individuals, but some people are more at risk than others. Risk can't be predicted with some accuracy for large groups of people. So when you start to group people like by age group or by whether they smoke or not, you could start to predict disease trends and risk. And insurance can shift from the individual to a group by pooling resources. So think about this. You reduce your costs if you start to put people into big pools. And the idea is that if we group people together, we could share the loss of one person. So insurance, think about this as a cost-benefit way to protect people in large groups. You start to spread out the risk. Now, you've seen this complicated, I've shown this before, but one of the big things I want to point out is that there's public financing and private financing. And public financing, you'll see that Medicare and Medicaid live under public. And that federal and state government are in charge of these two. Do you see that? They share the costs. Money comes in, it's public, that means it's from tax dollars, and it comes in, and also people contribute to Medicare. They actually contribute to Medicare. And then Medicaid is income criteria. And you'll notice that Medicaid and CHIP are right next to each other. And then private financing is either people are getting it from their employers or the marketplace. And I'm going to definitely put the marketplace interview that I did for the CHW class in this class, because I found the marketplace absolutely interesting. I'll put both of those interviews in there because I think they're very interesting and helpful in explaining how OHP works and how the marketplace works. So sources of financing, you can get it from, people can get paid. The providers can either get paid from private insurance, from public insurance, or uncompensated, like they just don't get paid, or charity comes in, or a person individually pays for it. So this is how people get paid. In the United States, if you think about hospitals and service represent half of total healthcare spending. So the majority of costs come from the hospital and from physicians and clinics. We could see that drugs definitely come in there with a cost. And then I'm curious now what the other health includes spending on other non-durable products such as residential and personal care. Interesting. So this is one of my favorite go-to sites. It's the Peterson Kaiser Family Foundation. You can get all kinds of information about the U.S. healthcare system from the Health System Tracker. I'm going to definitely put this website in there, and I want you to play with it. Health insurance coverage for the total population, and this is something that I find very interesting. Is that, and I definitely want you to click out on this, but I don't have it interactive here. But you could see that in the United States, 49% of people get insurance through their employer. 16 from a non-group insurance. That means that they're getting it outside of their employer and they're getting it from different means. 20% from Medicaid, 14% from Medicare, military, and then look, these are all the people that fall through the graph that are uninsured. Please know that that varies from each state. And so you will definitely see that some states definitely have more uninsured than others. And I want to tell you that that really depends on their Medicaid expansion, whether they adopted the Affordable Care Act or not. You'll see that that relates back to that. So it's really important that we have financing. And working Americans, a lot of them finance their own health care and subsidize those who cannot afford it. So that happens in the United States. Employer paid insurance is in exchange for salary. So I want to stress that when you get a job, and the employer's talking to you for the first time, you're meeting with human resources, you'll notice that they'll present the salary to you, and they'll often say, and here are our health care benefits. And so please know it's a negotiable item. It's a labor item. And it's definitely a part of the contract. And if you're unionized, or if you're part of a union or a forum or a group of people that are negotiating contracts, that health benefits is a big chunk of that negotiation. And Medicare tax is a type of prepayment for certain type of services. So I want to stress this. You are paying through Medicare. If you see on your payroll slip, you'll see a FICA and some other items in there, and that's your contribution into Medicare. And I think that's important to understand that this is a contribution of services too. Even though it's publicly funded, it's coming through the government, we are contributing to it. So there are 5 different types of private insurance. So if you need to understand back to that employer paid insurance, there are 5 different types of private insurance. And this is on page 132 of your text, and you could read around this. I also provided a health insurance explain for you to read the book and then watch that little video. And this is something you don't need to know inside and out, but you need to know that there's group insurance, there's something called self-insurance, there's individual private insurance where you pay into it. You might pay into a managed care plan, and then there's something called high deductible plans, which are catastrophic plans, like a $10,000 deductible, right? That you would have to pay into before the health insurance would even kick in. And this could really throw people off guard because high deductible health plans also do not cover a lot of different items. And I've actually seen people be burnt by those. So something to keep in mind. Definitely be aware of what private insurance you are getting. And being familiar with the insurance means you have to read your individual insurance plan. So insurance has its nature and purpose. There's something called a deductible. And this is the amount the insurer pays first beforehand. So that would be what you pay in. And it's paid by the plan. So let's say you have a $1,200 deductible. Then you would have to contribute $1,200 before your insurance would kick in. Copayment is anything that you pay out of pocket every time that you go to get health insurance. And coinsurance is paid by the enroller for. So let's say your insurance will cover $181. Well, I should say your insurance will cover 80% of a bill, and then 20% you have to pay. I started to do some math there, but you get the idea. So again, this is the percentage that you will have to pay, and then the other part you would have to, the healthcare would pick up. And so that could change by each procedure. This terminology is on page 131, and it's the idea of cost sharing. So it's the idea that with your insurance plan, you are doing something called cost sharing. So definitely take a look at that. So Sally, here's what this looks like. Sally doesn't feel well. She makes an appointment with her provider, and when she checks at the office, she has to do a copay, and that's when they say, your copay is $20. So she pays $20. Me doing my whoop. So $20 out of pocket. All right, and these copays could differ from each type of insurance or whatever was negotiated, right? So know that copay is always consistently the same, no matter what the service is. You come in, your copay is X dollars. Okay, so again, that is X dollars that your insurance says you have to pay. And the deductible is the amount a member pays before the covered services, before the insurance kicked in. So let's say Sally's deductible was $1,200. So right away, her bill now, she's gonna get a bill in the mail. And let's say she's paid nothing this year towards health insurance. So right away, whatever that big grand total bill is, let's say it was $5,000, right? It would be $5,000 minus the $1,200. That's still, she's going to still have to contribute $1,200 to whatever that emergency room visit was. And then whatever's left over of that $5,000 bill after she minuses $1,200, then the coinsurance will pick it up. So that might be 80% of that bill. So she will still get a bill in the mail. All right. And so that you have to do some math there, right? And it really depends on what emergency room she went in to, whether she's met her deductible for the year. And remember, each service could be a little bit different. But let's say Sally has been busting her ankle a lot, and she's gone in 6 times now. so many times so much that she met her out-of-pocket expense for the whole entire year. Sally would definitely be a big user of insurance, and that's when 100% will come in. And I have to tell you personally, this varies per person, but if someone's using the healthcare insurance a lot and is really, had a bad year, it's really sick, that could be possible. But for the person who's healthy, they probably will never see that out-of-pocket maximum for the year. So don't bet on that happening really quickly unless someone is sick. So one of the big things that the Affordable Care Act did, and this is on page 135, is it really started to impact how we do our insurance and what services would be covered. And so one of the big things is it came in and started regulating that preventative services had to be covered and immunizations had to be covered, and that there was no lifetime limit on benefits. And the other big thing it did is it said that you can't have a be denied coverage because of predisposing conditions, and it kept people on their insurances, the children on their parents' insurance up to a higher age limit. So I have an interview there on ACA that I would like for you to listen to. She does a great job of providing an overview, and I highly recommend that you listen to the ACA interview. And then this is covered in your book on page 135. I also put some items in the module that you can download that you should keep. ACA really started to change our insurance coverage, and one of the big things is it also increased coverage. So there were some big mandates. They have to have insurance. Not having insurance requires a tax penalty, and that's about sharing risk. Okay, I know, see, if people don't carry health insurance, and you'll see with Sick Around the World with that video that he did, that when you go to each country, if people aren't insured, that can actually create a big risk. So by everyone having insurance, we start to share risk. It's an economic cost-benefits analysis thing. And the big one is that now insurance could be through a government-run exchanges, either state or federal, and that there's subsidies for low-income people. And so that's something that I'm going to put both of those interviews in there that are also in my community health worker class. But I feel like it's really, I got really good reviews from the community health worker class. These really helped them. So I will definitely drop it into this class too. The ACA mandates that there are 4 exchange that you could purchase into 4 plans. That employer must offer insurance for those working at least 30 hours a week, for those working a minimum of 30 plus hours a week. I should say that, because if you're working under 30 hours, that insurance is not mandated. So they have to work 30 or more. Coverage cannot be denied for pre-existing medical conditions. And now children and adults can be covered until age 26. These are big changes. So by the Affordable Care Act expanding coverage and providing more opportunities for people to get insurance, this should shift now into how providers, and when I mean by providers, I mean medical providers, right? Your doctor, your dental carrier. These are like, medical people, right? Like doctors. And this is my talent now. We're writing a doctors, etc. of drawing with a mouse. I'm getting better. So, these are your medical providers. And providers could be paid either through public, like Medicare, Medicaid, CHP, Veterans Affairs, etc., or through private insurance, and each rate may vary. So this is something in the United States that you could go to different hospitals and there'd be different rates. So the first one that I'm going to talk about how people could get paid is through public insurance. And the 2 I'm going to highlight are Medicaid and Medicare. These actually pay for a substantial amount of healthcare services in the United States. So much so that we would say that our health insurance really does have a public model. It's not completely private at all. Public is definitely in there. And one of the big public financing tools is Medicaid, and this is the website for Medicaid, medicaid.gov. And under Medicaid, you could see that there's information on CHP, right there, Children Health Insurance Program, and Medicaid, and these actually work together in a sense that if a child doesn't qualify under Medicaid, they could under CHIP. And so this is one of the big things, is that this is a great website that really goes over Medicaid. And Medicaid provides coverage to low-income people, and so they have to meet a financial criteria. And I have to tell you, it really differs from state to state, and there's a lot of gray area. So it's really important to watch the Oregon Health Program overview to really realize that if someone isn't sure if they qualify for OHP, they should. So in Oregon, it's called OHP. In California, it's called the MEDICARE program. And so each state has a different name for this, but it's Medicaid. And it's one of the largest providers for healthcare in the United States, big time. And then Children Health Insurance Program is matching funds to state to provide health coverage to children and families. And so it works in conjunction a lot of times for Medicaid. And then there's something called Basic Health Program. And this is a program to really help states to provide more sliding fee scales for those people who income fluctuates below Medicaid and CHP eligibility levels. Medicaid is for children through 18 years and families with low income, and this could change. So this is in 2020, so this number could change, right? So you would have to actually look that up, and I'll show the website that. People who are pregnant or have low income below 138%. Certain parents or caretakers with low income. And most seniors and people with disability who receive cash assistance from supplementary security income qualify for Medicaid. The CHP is part of the Social Security Act, and it definitely is for children. And it really expands who could be covered. And when created, nearly 1/4 of children were uninsured, and it expands Medicaid. So it's really definitely something that works in conjunction with Medicaid. In a sense that if someone isn't covered, a child isn't covered, it can help a child through CHIP. So one of the big things with Medicaid is that doctors sometimes are definitely not reimbursed, and some physicians absolutely will not participate in it. So in other words, they don't get paid enough, they can't do it, and so you will find sometimes doctors are hard pressed to actually accept OHP or Medicaid or Medi-Cal. Wherever you're at, each state calls is a little bit different. Each state decided whether to expand Medicaid or not. And this was originally required by ACA, but the states opted out. Some opted not to expand it. And so you'll see insurance rates change. And some evidence indicates that ACA is linked to Medicaid expansion and has resulted in a better access to care and utilization. So it is definitely something that has its benefits. So you'll see that before ACA expansion, there was a group that were not eligible, but with the Medicaid expansion, this actually increased the number of people who are eligible with Medicaid. Medicare, now I'm going to go to Medicare, which is different than Medicaid. So Medicaid is like financial aid, income criteria. Medicare is, we care for those 65 plus, disabled people who are entitled to Social Security benefits, and those with end-stage renal disease. This is what Medicare covers. You definitely contribute to Medicare. And if you see it, FICA is this. This is what the contribution is. And so that is a contribution that you'll see later going towards Social Security and Medicare. If you don't see this, that means your employer is not contributing to FICA, but a lot of employers, you'll see that on the paycheck. All right, and that goes for a lot of people. Doesn't matter how many hours you work, this is something that will pop up on your paycheck. There are 4 parts to Medicare. There's Part A that everyone gets through hospital insurance. Everyone gets that. Everyone. Part B, these start to shift. Not everyone gets this. Part C and Part D. So you'll see that this can be something that is that can shift. And I actually put the website down there that's in white there, Medicaid interactive chart. I think this will really, I'll try to put that into our module so you can play with that if you're interested. Medicare does not cover vision, eyeglasses, dental care, hearing aids, and many long-term services. No. This is a problem, all right? Because how many times do dental care does definitely lead to our ability to be healthy. Hearing aids are a basic need function. And vision, I think vision is a very important, right? And long-term care services. This could be problematic. Sometimes it's not covered under Medicare. Hospice is covered, but long-term care services could be problematic. Again, Medicare does not cover. And this is something that could be changed with policy efforts. So how do providers actually get paid? How do they actually get paid? I went over some of these funding services. So how do they get paid? And so one of the big things is that it's a third-party system. So it means that the insurance companies will pay back the provider by reimbursing the provider for services. So a lot of times it's reimbursement. Sometimes people will get paid by fee for service. So like the provider will say, hey, pay me directly, and then bill your insurance company. And that is a pain. But again, sometimes 1, they could get reimbursed. 2, they could do fee for service. They could bundle their prices and then get all the services reimbursed. Or they could do this thing where they have different types of scales on how they get paid. And this is something that your book goes into, is how do people get paid? And this definitely can vary from provider to provider. They also have different models for reimbursement. So like the more days that you stay in a hospital, the less money the hospital starts to get. That might explain to someone who's like, wow, they sure got me out of the hospital quick, right? So it also, research shows that the more someone stays in the hospital, the more they can get susceptible to different types of infections. But the reality is it could be problematic when you look at how a hospital is getting reimbursed. Again, I went over this already, but fee for service, this is when the charges are set, and then they do a fee for the service, and then a bill will happen separately. They bundle their payments, and definitely where some people get all their everything bundled into one payment for a entire episode of care. And they could also do this thing where they Medicare actually will just reimburse physicians for relative value, and which sometimes doesn't really pay them for what they're delivering. So again, sometimes you'll see doctors not accepting Medicare because they're not getting enough money for the service. Or sometimes it's fraudulent, and sometimes people will submit claims that are not valid. So realize that there's something that we could actually have fraudulent things happening with these methods too. And the last one I want to hit on is something called capitation. And this happens a lot. This is something that's typical, especially with HMOs that we're going to be talking about later. This is a new term, but health maintenance organization, just like Kaiser Permanente, where a provider is paid a set monthly fee per enrollee. So the more people they have, the more they get paid. And this will explain why some doctors have such large caseloads. I've already showed this slide. You got that. All right, finally, I'm going to end on this slide. One of the big things that we could do with our health care system is to start really thinking about doing some reform initiatives to change how people get paid. So why not shift to value-based payments to hold providers accountable for cost and quality? Not just how many people or patients they saw, but what's the outcome? An increased shifting of risk to providers, which probably the providers aren't too excited about that at all. But because then who wants to assume more risk? And they're already working so hard. But one of the things that they're talking about is new payment arrangements for Medicare to be worked out to include more bundled payments, shared savings arrangements, and risk sharing arrangements. So this is something that needs to be worked on, and this is something that your book definitely starts to talk about when it talks to how can we do some reform efforts to address the finance issues. Here are the themes that I'm going to have you focus in on, and I look forward to seeing your group discussions this week as you dive into these different areas. And if you have any questions, please make sure to email me. Thank you, and have a great day.